My name is Eileen.Dudley and I am the Patient Safety Manager and the Maternity Clinical Network Manager here at the Oxford Academic Health Science Network, and I will be the chairperson for this webinar. With me are Christine Harding, Consultant Midwife at Royal Berkshire Hospital, and Wendy Randall, Consultant Midwife at Oxford Hospitals, and my colleague Fran Butler, who is hosting this event. The webinar will run as follows. The masterclass will take approximately 30 minutes and will incorporate fetal heart sounds. Please make sure that your volume button is turned up on your computer or laptop to ensure that you can hear the audio. You will need a second-hand watch, timer, or your phone to count the fetal heart sounds. We have muted your microphones at our end to avoid distraction and noise on the recording. We are using the Future NHS collaboration platform as a secure repository for resources, including this presentation, answers to the IIA assessment on e-learning for health, and a summary of all your frequently asked questions. Midwives who are in an education role or in a fetal monitoring specialist role, and therefore likely to be supporting a midwife, should she or he be unsuccessful in attempting the assessment on e-learning for health, will need to email me directly, including their role, organisation, and signature, so that I can be certain that access to the Future NHS platform is appropriate. It is important that the answers to the assessment are protected and shared only as appropriate. Once the masterclass is complete, Wendy and Christine will deal with the questions that have come through on the chat box. If there are any additional questions that you think of later on, please send them via email to me, and I'll give you my email address a bit later. It is my pleasure now to hand over to Wendy Randall and Christine Harding, the two consultant midwives who are leading today's masterclass.
Good morning, and thank you ever so much for joining us. So Wendy and I, first of all, want to just explain what's led us to do this training programme. So root cause analysis from investigations has highlighted some inconsistencies in practice. And these may well be inconsistencies around when the fetal heart rate is heard or listened to, how long we're listening to it, what the significance is of what has been heard, and what is actually documented. So we've been teaching intelligent intermittent auscultation based on physiology for some years now, and we've always wanted to explore how we can be more accurate in undertaking this skill, and therefore how to be competent at undertaking this skill. So education and training packages today don't seem to be working, as we continue to have poor outcomes for babies born to low-risk women. It was about 3 years ago that we embarked on this journey to provide a training package that uses fetal heart sounds to train and assess competency. And it's really been revolutionary in our services, and we therefore want other maternity services to benefit from it as well. So we've been amazed to discover from our training and sharing of our resources that practice is focused on the number that's obtained when you count the fetal heart rate for a minute or read the number displayed on the sonic aid screen. And we challenge that this gives you very little information. And actually, we should be listening and assessing the baseline fetal heart rate. And we'll talk about this in a bit more detail as we go through the webinar. We've included the FIGO physiology guideline as pre-course reading in our module, as it reinforces the physiology that we should be considering as part of our risk assessment in how we can determine whether a baby is coping in labour or not. It's important to highlight that hypoxia evolves with decelerations before an increase in the baseline heart rate, and both of these can be detected with intelligent intermittent auscultation. Changes in variability come much later on in the evolving hypoxia pathway, and IA can't detect this. You will hear us talk about variation in the fetal heart rate during this webinar, but please don't get this confused with variability, as they are very different concepts. It's also important to know that infection can develop, and this can be picked up with a rising baseline heart rate too. So it's important that IA skill maximises the potential to detect and take action if issues are identified as being developing. Our package is going to take you through a holistic approach to ensuring the safest outcome for mother and baby.
So, my name's Wendy. When we carried out root cause analysis in investigations, it astounded us about the different practices midwives adopted when undertaking IA. Some midwives told us that they looked at the woman and when they saw her relax, they knew the contraction was finished, and that was when they started listening to the fetal heart. Some midwives say they ask the woman to tell them when it's over, and then they start listening. When I used to speak to women who'd had babies who'd had been born in with poor outcome, I used to ask them if the midwives had their hand on their abdomen before they listened in to the heart rate, and none of them had experienced that during their labours. And the other interesting thing from doing this training package was asking midwives and watching them in practice, and basically some midwives don't start counting until it's at the appropriate point on their watch. For example, when at 3, 6, 9 and 12, which is interesting in itself because you miss those initial moments after the contraction. So we would say these practices are unacceptable. We know that if we exercised, if we ran up a flight of stairs and struggled at the top of that flight of stairs, it would take us some time to regain our breath to be able to tell you that we're okay, or for us to look okay. And therefore, it is so important that you listen whilst palpating a contraction to ensure that you are listening in immediately after the contraction. So we do make quite a point about this in our teaching session. We aim to listen immediately after contraction to gauge how that baby has coped with the contraction. And if you miss those crucial seconds for whichever way you've been listening in before, it may mean that you miss the deceleration that's recovering, or a tachycardic overshoot that tells you the baby is struggling to cope with the stress of the contraction. Therefore, you miss those important clues that you're meant to be looking for as part of your risk assessment. Therefore, as I can reiterate again, we believe this slide is one of the most important aspects of practice that midwives need to get right. Some midwives have said in training that they need an extra set of hands, especially if the woman is in the pool. There's always a way around this. The partner can always switch the sonicade on when prompted to, if you're palpating contraction and readying your sonicade to monitor the heart rate. It is a crucial step, so we have to find a way to make it work in practice. It's really important everyone participates in this, as this is the bit that helps to either reassure them that they have an effective skill or that they may need to make some changes. When we do this session in a classroom, we ideally get you to call out the answers so that you can see the variety of answers that are obtained by different people listening to the same sound. However, this isn't possible in the webinar. So we're going to play this sound shortly, and what the information that you have on the screen, and the baseline heart rate has been around 110 to 120 in the picogram to date. This is a low risk situation. This woman is having her first baby and is in the first stage of labour. So you're going to hear the sound now, and when you hear the sound, you can presume that the contraction has just stopped and you are immediately listening to the fetal heart rate. Okay, so when the midwife hears the sounds as you have, we then ask them the following questions, as these are part of their risk assessment. So let's look at the answers together. I understand quite a few of you are listening to this in smaller groups, and it may be worth discussing amongst you if there's a variance in the numbers that you achieved. But hopefully you all achieved these answers. If you did, that's brilliant and very reassuring. If you didn't, we need to consider why you didn't. So we can share with you that we've run these sessions in our maternity services and others. We've now shared it with at least 20 other maternity departments prior to launching the e-learning module. And we found that more than 50% of midwives and obstetricians get this wrong. They consistently have too high a number, and that is usually because they've included the acceleration that you heard in the middle in their. So again, we want to reiterate that if your method is working for you or it's working for the midwife that's being assessed, we're not asking them to change the way they're counting. But what we're doing is, for those that haven't been accurate in terms of the measurement, is we're asking them to think of a different way to do it. If you count as per the NICE guidelines for 60 seconds immediately following a contraction, and please ignore the numbers on the left at the minute, you will get 131 beats per minute. You can have a variance in your number if you listened for 6 seconds and multiplied by 10, or listened for 15 and multiplied by 4, or any other option that you've been taught and practiced over the years. However, I'm going to share with you a method that I was taught. I'm not sure by whom or when. I've been doing this for 25 years, but it helps to identify the physiology behind what you're listening to. So if you count in 15-second blocks, which are what the numbers are to the left of the equal sign, you will see that there is a variance in the numbers. The variance should highlight to you that you need to listen for longer than the 60 seconds, as you cannot define the baseline rate here. Remember, from what Christine was saying, we're not talking about variability, we're talking about a variance in the numbers that you hear. So therefore, in practice, if you just listened for the 4 lots of 15 seconds, or the minute above at the top line, you would see that you needed to continue to listen for longer. And if you listen for longer, you can see that you have similar numbers that appear. So you have the 2 numbers at the beginning that are similar, and the 2 numbers at the end that are similar. And this would give you a baseline heart rate of 116 beats per minute. And the numbers in the middle, the 35 and 39, would denote your acceleration that you heard. So you can see that there is a difference in the numbers that you achieve depending on how you're counting the method. And when we have done this in a classroom setting previously, we have had people calling out numbers from 100 up to 160 beats per minute, all for the same sound. And this is why it's so important for us to develop a standard where we're all practicing and achieving the same results. Now, in practice, because accelerations aren't as frequent in labour, it's likely that you may hear 4 very similar numbers, and therefore 60 seconds should be enough to help you define your baseline rate. However, midwives need to be able to identify whether there's a variance or not, and we challenge that most traditional ways of counting won't help you achieve that accuracy. So I apologise for focusing on the CTG, but we feel this strengthens the importance of monitoring baseline fetal heart rate in labour. The circle is the sound that we recorded with the help of Alan Ingalls, who is a technician in Oxstar, the simulation suite in Oxford. And the red line that you see is the fetal heart rate that you get if you only count for 60 seconds and include the acceleration in your count. The green line denotes the baseline rate that we count when we do intelligent intermittent auscultation. And I'm sure you're all aware of the significance of having a baseline rate difference between practitioners.
So step one, we feel, is arguably the most important step when undertaking intelligent intermittent auscultation. This is the step when you're identifying that you've got the right tool for the job. So it's about doing that risk assessment, looking at maternal well-being, looking at fetal well-being, and looking at how labour has progressed up until this point. So it's only at this point that you can really do a thorough assessment and decide that intermittent auscultation is the right. It's really important because you won't already have a baseline on your partogram that you're able to judge whether you've got a stable baseline. So it's really important to consider whether the baseline you identify is appropriate for gestation. And therefore a baseline that's quite high, at the higher end of normal for a lady who's post-dates, would hopefully lead you to feel that actually that's not appropriate, and therefore there may already be some pathway on that hypoxic journey happening, and therefore intermittent auscultation is not the right tool. So we encourage you to undertake your observations of mother and baby, listen for the baseline, also listen to exclude acceleration, or to exclude decelerations, I should say. But also, if you can hear the fetal heart during an acceleration, you know that you've got a well baby. And it's only knowing that you've got a well baby at the start does it mean that intermittent auscultation is the right tool for you to continue with. Contractions obviously are vitally important, and we can't really assess how the baby is coping in labour without considering the contractions. So please always remember your contractions, and in particular the resting tone that you've got in between.
So throughout our teaching package, we have different sounds that demonstrate different things that a midwife may encounter as part of her risk assessment. I'm only going to share one more with you now as part of this webinar to reinforce what I was saying previously about counting the baseline heart rate. So please, can you take part again? Those of you who didn't have an accurate fetal heart rate with the last sound may want to practice 15-second counts this time to highlight your baseline rate. Okay, so again, we're asking the same question. What do we think was happening at that time? What we're going to do is take you through, and this will obviously show the answers to the questions. We're going to take you through the 15-second count method again. So if you counted for 60 seconds, you would have the following numbers. You can hopefully see that these numbers are ascending. What do you think? Would you be happy to continue and plot the fetal heart rate at 144 beats per minute? If you decided, like we did, that there is a variance in the numbers, then we should listen for longer, and you would get the following. From the blue circles, you can see that the 4 numbers at the end are similar, where the numbers at the beginning are lower. This tells you that your baseline is actually 158 beats per minute. And what you heard at the beginning was therefore a deceleration that recovered over the first 20 seconds. So we have to consider what are the implications for this. Those that counted for 60 seconds might be reassured that all is well, whereas those that have used intermittent auscultation skills will have identified that there was a deceleration at the start. And this example thus reinforces the point about when you start listening after a contraction, because if you delay listening because waiting for a woman to show that she's recovered from the contraction or other reasons, you will have missed that subtlety at the beginning that tells you that this baby is using extra resources to recover. So this is the CTG that we recorded, and again you can see from the circle the specific point that we recorded, and I hope you can see that this is why we need to help midwives, some midwives, to adapt their practice. There are quite a few examples in our e-learning module, and the benefits of being able to access this at home is that midwives can listen as often as they like and really focus on improving their skills. From an organisation perspective, when the midwife shows you the certificate to say she has passed, it will hopefully reassure you that you have a competent workforce.
So step 2 is the continuous assessment. So this is the ongoing, continual monitoring of the fetal heart every 15 minutes in the first stage and at least every 5 minutes in the second stage. Really important that it is the baseline that's plotted on the partogram as a single figure and that you observe that trend. We're asking you to listen for variation, listen for decelerations and accelerations, and be very mindful of accelerations that occur following the contraction. So if you're consistently hearing an acceleration as soon as you start to auscultate, you've got to question whether this actually is an acceleration or is it actually what we call overshoot. Now, the only way that you're going to know that is if you perhaps listen to the fetal heart rate during a contraction, not something that we advocate for you to do on a regular basis, but every now and again, if you're suspicious that you're hearing something which may be an acceleration or may be overshoot, the only way you're going to know is if the sound that you're hearing is on the back of a deceleration that might have occurred during the contraction, or whether it's an acceleration which has to start and then return to a stable baseline. Active second stage is really important, and it's at this point where you need to have that extra vigilance. So there's been lots of questions around passive and active second stage, and if you use a very intelligent way of doing your auscultations, you'll know that as soon as there is any active second stage, that's where the risk to the baby increases, and therefore that's when you need to increase your auscultations. And this transition between the stages is absolutely important, and one that you need to be very mindful of.
So again, due to time restrictions, we cannot play all the sounds during the webinar, and we're sure you will have some questions to ask afterwards. So some people ask, how am I going to count in 15 seconds in practice? And I will try to explain how to do it, but please bear with me as it's difficult to explain without a flip chart. If I get a count of or around 30, I know that my baseline is going to be around 120 beats per minute. So if in my count I have 29, 31, 28, 30, I've adjusted in my head that the first two numbers would equate to 120. However, the next two numbers, the 28 takes it down to, so thus my baseline would be 118 beats per minute. Some midwives have said that they would need to write them down, which they can do if it's practical. However, we all know that we can keep times in our head around the birth. We've all done the 48 crowning, 50 head, 52 body, 53 centimetron, etc. So it does come with practice. Thus, we should be able to hold those numbers for a short time until we can add them up. If it helps midwife by writing them down, great, but it can be done by midwives too. So again, the similar questions are asked, and the example that we recorded this time is a baby's heart rate that decelerates and doesn't pick up. In this example, if you count in 15-second blocks, you get 25, 20, 16, 15. Now, if you only count for 6 seconds and multiply by 10, or 5 seconds and multiply by 12, or however you do it, you might get a rate around 100 and stop listening. However, if you listen on, it does highlight the deceleration further, and it does reinforce that we need to listen for at least 60 seconds after contraction.
Step 3 is about documentation. Now, we all use lots of different methods for documentation in our trusts, whether they be electronic records or paper records. So it's important that your midwives in your organisations understand how and where to record what they're hearing. And we certainly don't advocate that they record on the partogram and then duplicate what they're recording in the records as well. The partogram is really important for documenting that baseline, because it gives you an overall picture of the progress of how the baby is coping. And you can also record maternal observations on the partogram. There needs to be some evidence around the discussion you've had with the woman, your agreement on using intermittent auscultation, and obviously your risk assessment, ongoing assessment with periodic comments around contractions and the presence or absence of accelerations and decelerations. And obviously the plan of care is vitally important to be recording, along with the reason for recommending moving over to a CTG if that's your plan.
So we've got these pictures to reiterate our point about monitoring baseline heart rate. In the picture on your left, if you just plot the number you get without working out a baseline rate on a partogram, you can see how it skews the picture of fetal well-being. However, if you work out baseline heart rate, it enables you to see the rise that is occurring, which can either give you signs of developing hypoxia or sepsis. So again, we're going to pass these today, but they are available for you to access following the webinar or in the e-learning for health module. The questions are the same as before. This time you can see that we've captured a tachycardic fetal rate with decelerations. We would anticipate with your IIA skills that you would have picked up on the evolving hypoxia before you got to this stage, but it also depends when the woman presents in labour. Again, if you only count for 60 seconds, the deceleration that occurs at 40 seconds into the sound may bring your rate down to an acceptable level, which may mean you miss the extent of this developing hypoxia.
So what are you going to do if you hear something that you're suspicious of? And that might be that you're having difficulty hearing the fetal heart. You're not sure whether the maternal pulse and the fetal heart are similar, and therefore you can't be sure that you're definitely picking up the baby. If your baseline is abnormal or rising, as you can plot it on your partogram, if you hear any decelerations, if you have contractions occurring more than 5 in 10 minutes, and we talk about and the number of contractions per 10 minutes, but what we're actually referring to is the resting tone in between. So if you have a lot of very short contractions, but you've got good resting tone, then that's okay. But if you may have fewer than 5 in 10, but they're lasting longer, and therefore you don't have at least 60 seconds of resting tone, then that's a significant risk for the baby. So any of these things, or any risk, take action. So that might be by increasing the frequency of your auscultations. It might be listening after the next 3 contractions, or listening during and after a contraction. It be thinking about the bigger picture and looking for a cause. What is it that you can do to improve the status of that baby? But we'd encourage you to summon help, and we'd encourage you to recommend moving on to continuous monitoring and transferring into an obstetric-led environment if you are not sure that your baby is well. And obviously in second stage, if you're not able to comply with the requirements for intermittent auscultation, you need to get some help. And that might either be someone to help you support the mother, or to be able to scribe for you. It's really important to know that if you have put a CTG on because you're suspicious of something, that if it is completely normal and that those suspicions haven't been confirmed, that you can take the CTG off again and revert back to intermittent auscultation. And we'd encourage the fresh eyes approach to be used in this situation, to have a second pair of eyes to confirm with you that the fetal heart is fine, and you can therefore revert back to intermittent auscultation.
So as you can see with the pictures of the speakers on this slide, we actually recorded 4 short sounds that demonstrate tachysystole. Again, the midwives are asked the same questions, but what happened, we highlight the importance of being able to count for at least 60 seconds. The presence of tachysystole makes defining a baseline impossible, and therefore midwives should be prompted to convert to continuous fetal monitoring. This is where we encourage midwives to think about the whole picture and not just the fetal heart rate, which sounds stable as the baby is coping at the moment, but doesn't reassure you as to how long the baby will cope. Thus, taking a more holistic approach than just listening to the fetal heart rate. This was a low-risk woman who was put on a CTG due to tachysystole. Unfortunately, an hour later, there was a prolonged bradycardia, and this woman had an emergency cesarean. There was a placental abruption, and fortunately, the mother and baby were okay. If this woman hadn't been on delivery suite and had a Cat 1 cesarean section, the outcomes would have been very different. So IIA identified that this wasn't a normal situation, and therefore she was transferred for continuous monitoring at the right time.
So this slide highlights nice recommendations for moving over to continuous monitoring, and it's something that's obviously been in our practice for quite some time. There's a few things that we just wanted to highlight. One of those is about meconium. So evidence tells us that old thin meconium suggests that that is well diluted, there's plenty of liquor, and it's of doubtful significance. However, there's more emerging evidence coming out all the time that says that maybe we should be paying attention to the thin meconium now. So that's for your organisations to identify. But at the moment, this is the nice recommendation, so that's what we're teaching. Obviously, we've talked about tachysystole, oxytocin use as well. Temperature is really very important. And the appropriate baseline we've already highlighted as well. So in summary, our teaching is encouraging you to recognise the limitations of intelligent intermittent auscultation. It is a listening skill. It's only suitable for well babies during labour with no identifiable risk factors for hypoxia or infection. It's absolutely crucial that you're doing it at the right time, that you are assessing the baseline, and that you're confirming the fetal well-being at the outset, and that you use a very holistic approach to this. And if there's any doubt, you're advocating that you should recommend continuous monitoring.
So when midwives have completed the learning package for intelligent intermittent auscultation, we encourage them to take part in the assessment. When we introduced this training over 3 years ago, we were initially overwhelmed by the feedback from midwives. There were the midwives who felt it supported how they practiced and shrugged it off as unnecessary for them. Those who felt it was eye-opening and wanted to change their practice, and those who were disgruntled that we were asking them to change their practice of many years' experience. We reiterated, and will today too, that you don't need to change your practice if what you're currently using today gives you the right answers. Your way is working. You would only know that, though, if you have the opportunity to do this assessment and obviously pass with 100%. The people we ask to change their practice are those who aren't getting the answers correct, and thus their way is not working for them, whether they've practiced for years or not. When you start the process, you will wonder what to do, as there will be a percentage of midwives that don't pass the assessment. This does get less each year. In our first year, it was about 15%, which I'm sure you will know is not a small amount. Therefore, you need to find someone to lead on supporting the people that don't reach the pass mark. Our fetal monitoring midwife meets and upskills these midwives. We have shared resources to help them with this. As well as this presentation, we have the assessment from the module, another test paper to retest them. As for implications for practice, we don't let midwives work in practice in providing intrapartum care until they have achieved the pass mark. Our fetal monitoring midwife is brilliant at picking them up as soon as possible to minimise any distress or embarrassment for them. But in the interim, they either work in a non-intrapartum area or they are second midwife on call for home birth or midwifery-led unit birth. It's up to you how you run this in your units. We just felt that midwives and organisations were vulnerable if we knew a midwife hadn't achieved the designated pass mark and we let her work in an intrapartum environment and there was a poor outcome. So hopefully we've described that process for you. I'm going to pass you over to Eileen, who will tell you more about how you can monitor the use of the package in your area.
So hello, it's Eileen speaking, and this is just to give you a visual sort of a look at what the your e-learning for health pages will look like. So once your midwife has completed the e-learning and she's chosen to do the assessment, she then must choose to give the practice development or education midwife an opportunity to share basically give her permission. And then once the practice development and fetal monitoring midwife has that, it might be that there is, for example, the director of midwifery or head of midwifery might want access as well. Then it is possible to follow the instructions on the screen. It's very straightforward, and your PDM will be able to download a report. You'll be able to use a time period in which to access that. And this is an example of what it will look like. So she'll be able to run the report, download it as a PDF, or import it straight into her database. E-Learning for Health have an excellent support system. So any problems that your PDNs or fetal monitoring midwives might have, the first port of call would be directly to the help section on the E-Learning for Health. However, I'm really happy here at the AHSN to help individual queries if there's an issue. So on our e-learning, on our Future NHS collaboration platform, which is a secure site that Wendy referenced earlier on, where we are going to store information on the assessments, answers to the questions, and these presentations as well. So it's a train the trainer hub, and it will allow your PDMs and your fetal monitoring midwives to support a midwife in practice should she be unsuccessful. Now, it's very important that access to this resource is just for the midwives in education roles, because we want to make sure that it's appropriate. It's very helpful for me therefore, to have contact details for your practice development midwives, your fetal monitoring special midwives in your organisations. So they just need to email eileen.dudley@oxfordahsn.org with their name, their role, their organisation, and their email address, and I will do the rest. So I'll make sure that they get invited to the future NHS workspace. That invitation coming from me will come out later this week, and we'll share these resources later this week because we want to make sure the quality of the recording is excellent. And the invitation email will remain valid for 28 days, and I would encourage any practice development midwife or any fetal monitoring specialist midwife who knows she's contacted me and she hasn't received anything to first of all check her junk email and then email me again, and I'm sure we can sort it out. Once you get access to the future NHS collaboration platform, this is what you'll see. And you can see we've identified the intelligent intermittent auscultation trainee hub with our little pink logo, so it's very easy to actually pick it up. So I just wanted so you could see what we looked like, because it's a bit difficult when we're not doing this face to face. So Christine on the left and Wendy and myself, Eileen, we really appreciate your time, appreciate that you've taken the time to dial in. If one of your questions has come through, since we're just closing this, we will make sure that they're all answered, and we'll get back to you, to your practice development midwives, and make sure that they have access to all of the resources. Anything else, just please drop me an email. Very happy to help. Thank you very much. Goodbye.